Hello everyone. So today we will cover the topic peptic ulcer disease. So we know the two types of the peptic ulcer disease. The commonest one is the duodenal ulcer, right? So we have two kinds of peptic ulcer, gastric and duodenal. Now, where is the most common site of duodenal ulcer? It is the first part of the duodenum. It is the bulb. Now you have to understand a thing called erosion versus ulcer. So what is erosion and what is ulcer? So when the erosion is deep, it is called ulcer. How much deep? Okay, it should be more than 5 or at least 5 millimeter. So when the depth of erosion is more than or equal to 5 millimeter, it is called ulcer. Clear? So I told you that there are two types of peptic ulcer, gastric and duodenal. Duodenal being more common, and the most common site of duodenal ulcer is the bulb. And what is ulcer? It is erosion of more than 5 mm depth. And gastric ulcer is lesser common, and it is most commonly seen in the antrum region. In the antrum region, it is the lesser curvature. I'll show you the diagram again of stomach. We have already studied this topic. Okay, so if you recall that we have the fundus. First of all, this part was the cardia, the opening where the esophagus opens in the stomach, cardia, fundus, body, and the pyloric antrum or the pylorus. Actually, we call this part simply the pyloric part, and this pyloric part is actually divided into three parts. The first part is the pyloric antrum. It's a dilated part. This dilated portion is the pyloric antrum. Okay, so the pyloric part starts with pyloric antrum, or just simply we call antrum. Then after antrum, it is a narrow part. Suppose first part is dilated. Okay, this part is dilated. Okay, this is the antrum, this one is the antrum, and then it becomes narrow. This part, the narrow part, this narrow part is called the canal, and this is the sphincter. The sphincter is known as pylorus. So pyloric part is the last part of stomach. Cardia, fundus, this part is the fundus part. This part is the body part. Body is also known as corpus, corpus. Cardia, fundus, corpus, and the pyloric part, which has first antrum, then canal, and then the sphincter. The sphincter is in short called pylorus. Whenever you say pylorus, we mean to say the sphincter, and whenever you say antrum, we mean to say the pyloric antrum. So antrum, canal, and the sphincter, that is pylorus. Most commonly gastric ulcers happen in this part, that is the antrum part, and in the antrum part it is the lesser curvature of the antrum. That is where this location most commonly gastric ulcer happen. And if I ask you where most commonly NSAID ulcers happen, non-steroidal anti-inflammatory drug induced ulcers happen, again this is the location, because NSAID ulcers are mostly gastric ulcer. So NSAID is a cause of peptic ulcer, both gastric and duodenal ulcer, right? NSAID, and they mostly cause gastric ulcers, and this is the location. Now coming back, to the causes. Most common cause of both gastric and duodenal ulcer is Helicobacter pylori. What do we know about this bacteria? What we know about this bacteria is that it's a spiral or helical shaped bacteria which is having multiple flagella at its one end. Okay, it's a gram negative bacteria. Helicobacter pylori is a spiral shaped. It is not that much of spiral जितना मैंने diagram में बनाया. It is not this much of spiral, but yes, it's almost like this. And it is characterized by unipolar flagella. So this is unipolar flagella, multiple unipolar flagella. Now coming to other causes, NSAID. Okay, we have already discussed a little bit about NSAID. We'll discuss it again. Smoking is a risk factor of gastric ulcer, duodenal ulcers. We are talking about all the risk factors which are associated with peptic ulcer. H. pylori is the most common cause. NSAID, smoking, alcohol, Zollinger-Ellison syndrome, which is a gastrinoma condition where we have a tumor which is producing a lot of gastrin, and stress, both physiological stress and pathological stress. Now, H. pylori, about it, how does it causes the ulcer? See, H. pylori produces an enzyme called urease. What is the function of urease? Is to break down urea into ammonia and carbon dioxide. So urease breaks down urea into ammonia. This ammonia neutralizes the gastric acid. So when the ammonia neutralizes the gastric acid, it creates a hospitable environment for the bacteria. So the bacteria can live in a comfy manner within the HCl. However, this ammonia is not just providing hospitable environment for the bacteria, but it is also causing damage to the epithelial cells which line the stomach. Also, along with the urease, H. pylori causes chronic inflammation of the lining of the stomach and duodenum. This chronic inflammation brings a lot of inflammatory cells, neutrophil, plasma cells, lymphocytes, and these cells, they releases cytokines like these: interleukin 1, interleukin 6, TNF alpha, and these cytokines along with protease, which is also released, they cause damage to the mucosa. So ammonia is causing damage to the mucosa, cytokines causing damage to the mucosa. Then bacteria itself has few virulence factor like CAG-A, that is cytotoxin associated gene A, CAG, cytotoxin associated gene A, VAC-A, vacuolating cytotoxin A. So CAG-A, VAC-A, if you want to remember, it's okay. CAG-A increases the risk of cancer. If you are asked that what is the full form of CAG-A, it is cytotoxin associated gene, and vacuolating cytotoxin A. Of these two, cytotoxin associated gene is associated with the increased risk of cancer that is seen with H. pylori, because we know that H. pylori causes two conditions. First one is obviously malt lymphoma, which is very commonly heard, mucosa associated lymphoid tissue lymphoma, and second one is gastric adenocarcinoma, both with H. pylori due to this CAG-A. Next is how HCl production is increased by H. pylori, that causes the duodenal ulcer. So H. pylori increases the secretion of gastrin. This gastrin is responsible for producing duodenal ulcer. Remaining causes mostly जो हम लोग पढ़ रहे हैं, these are mainly responsible for stomach ulcer, but this HCl increased gastric acid production or secretion is responsible for the duodenal ulcer. Next, disruption of the mucous barrier by decreasing the production of mucin. It also causes gastric ulcer. So about gastric versus duodenal ulcer, gastric, G for gastric, G for greater with food, duodenal, D for duodenal, D for decreases with food. Because duodenal ulcer decreases with food consumption, so you will have weight gain in duodenal ulcer, because you are always going to take food so that your pain is reduced. But in gastric ulcer, because it is greater with food, you will decrease food intake, so there will be weight loss, both present with heavy gastric pain. Vomiting is more common with gastric ulcer, and only gastric ulcer has increased risk of malignancy. Duodenal ulcer is not associated with risk of malignancy. So when you are asked to do upper GI endoscopy, if you see in the upper GI endoscopy there is a gastric ulcer, you must take the sample for biopsy to rule out cancer. But for duodenal ulcer, you don't have to see the biopsy, you don't have to check the, you don't have to take biopsy, you just take the pictures and you give the report, because upper GI endoscopy is the gold standard for peptic ulcer disease. And also with the endoscopic evaluation, you should also check for H. pylori. So there are way to do that. First, obviously the simple ones like urea breath test, it is non-invasive. Stool antigen test, again non-invasive. But when you are doing upper GI endoscopy, you can take the biopsy and you can perform the rapid urease test. So duodenal ulcer, most common site, first part of duodenum, bulb. And if it is an anterior duodenal ulcer, it has risk of perforation. So remember, the anterior duodenal ulcers perforate, posterior duodenal ulcers, they bleed. Anteriors perforate, posterior bleed, and the one that bleeds, it bleeds from the gastroduodenal artery.